بسم الله الرحمن الرحيم. مواصلة في السلسلة حقت المحاضرات من المجموعة of a Sudanese psychiatrists in Sudan and overseas, which is an initiative that was started in 2023 for the group of Sudanese psychiatrists. This is the second session provided by Dr. Mohamed Abelalaim. And Dr. Mohamed Abelalaim, this is a small kind of introduction for him. He graduated from University of Khartoum, Faculty of Medicine in 1976. Following that, he trained in psychiatry in United Kingdom, where he achieved the DPM in 1983. And then subsequently, he achieved the MRC Psych in 1984 and in the FRC Psych in 1997. He had a significant role in establishing psychiatric services in Qatar, where he became the medical division, where he established psychiatric service, the medical division in the Ministry of Interior between 1985 to 1989. He took the role during that time in Qatar. Subsequently, he joined Hamad Medical Corporation in 1990, where he held the position of the chairman of mental health services between 1994 and 2005. He also held the position of the chairman for Fitness and Disability Committee, Ministry of Health from 1992 to 2006 in Doha, Qatar. Other roles that he had was the acting manager and program director for Social Rehabilitation Center, Supreme Family Council in Qatar Foundation between 2007 and 2011. And he was the member of the Permanent Committee for Narcotics and Substance Abuse between 2005 and 2016. Additionally, he had extensive role in clinical practice, teaching, training, and education of several trainees. He provides an expert opinion on request for the court for investigation of adverse outcomes and sentinel medical events. And also he's actively involved in rectifying medical dilemmas as being part of the Hamad Medical Corporation Medical Ethics Committee since 2002. Without further ado, I will welcome Dr. Mohamed, and he will start the session.
بسم الله الرحمن الرحيم. السلام عليكم. شكرا جزيلا الدكتور ياسر. أنا سعيد جدا حقيقة بهذه المشاركة، وأحيي جميع الأخوان والأخوات وأولادنا وبناتنا. وأنا سعيد غاية السعادة أن أكون أنا المتحدث الثاني بعد أستاذنا وأخونا الكبير، وأقول من كل أعماقي ووجداني أخونا الكبير دكتور الزين عباس عمارة. وحقيقة أهنئ اللجنة المنظمة الدكتور ياسر الدكتور لؤي وكل الذين يقفون وراء هذا العمل، وأتمنى لهم النجاح والتوفيق. نعم، مشاركتي Psychiatry and Death. I thought this is I mean, it might be a neglected topic, which it need really that if you can shed some light on it, that might be more useful to all of us. In psychiatry, we do encounter the objective of this talk is to, we know that in psychiatry, we encounter less deaths than other specialties. For example, our colleagues in ICU, medicine, surgery, traumatology, they encounter more deaths. But in psychiatry, we encounter less death, but it is mostly horrific, and it has got a special significance. And there are new trends: death by suicide, homicide, physician-assisted suicide, euthanasia. This is all part of our specialty. The issue of death and anxiety as a diagnostic identity, I think it is quite important, but unfortunately it is underreported, underdiagnosed, and not optimally managed. And the death and anxiety as a clinical entity, it comes, to my attention at the time of COVID-19 pandemic. We know that COVID really affected all families, or people lost their loved ones, friends, relatives. And personally, I encountered some few cases through this anxiety, which is fulfilling the criteria for a specific phobia. Another issue, which is life expectancy. There is a plethora of evidence indicating that psychiatric patients do live 10 to 20 years less than other population. This is really worrying. We have got a real responsibility in improving this situation. The attitude of medical staff towards this anxiety, euthanasia, and assisted suicide, this is an area of research. I'm working in a place, I mean, there is doctors and medical staff from all parts of the world, from all walks of life. And I'm not saying that some of them, they are advocating euthanasia, but I think we have to be careful about this subject. Some doctors, they do believe that if you go intensively in treating some patient and you know that is going to be very futile, you are not prolonging his life, you are just prolonging the act of death. And this, and in their opinion, there must be some sort of limitation to our interference. That, in a way or another, can be some sort of passive euthanasia. Issue of advanced directive and don't resuscitate policy. I have been involved in these policies, you know, over the years, and I have got a lot of concern about living wills, you know, regarding to what extent you need to resuscitate patient at the end of life, and who will decide. The issue of mourning and pathological grief, I think also it is an important one. I hope time will allow us to cover all this area. When I started preparing for this talk, I came across a paper in which accusing psychiatry as being the industry of death. And it happens that I came across a paper saying that there is a museum, you know, in Hollywood, in Los Angeles, California. This museum, they call it the Museum of Death. It was opened in 2005, and it was founded by anti-psychiatric group, the Church of Scientology, a guy by the name of, I think, Harold Butter or something like that. I mean, he established this school or this church in 1950. There is a lot of controversies about his thoughts. Basically, he is a fiction writer, and he has got a lot of fantasies and philosophical views. And of course, our friend late Thomas Szasz, he has got also his views, you know, about, in particular, the way psychiatry has been driven. It has been driven by the pharmaceutical industry, and it became entirely working for profit. The use of ECT, the political abuse of psychiatry. In Russia, at any stage, political opponent can be admitted under the term dissident psychosis, and they will be treated with ECT. This is obvious. What they're saying is not true, but there is a challenge for us: how to improve the stand of psychiatry, how to defend our specialty, how to destigmatize, and how to answer. I'm sure a lot of people, when they go and enter this type of museum, they might think that what they have been seeing might be, there is some truth in it. Okay, now I will talk about death anxiety. Death anxiety is called thanatophobia, and this term was coined by Sigmund Freud. It is a form of severe anxiety which is characterized by fear of one's own death or the process of dying, سكرات الموت وخروج الروح, and what will happen after death, عذاب القبر, or the death of others, of the loved ones. In its severe and morbid form, it is persistently It does interfere with everyday functioning by lowering the individual ego integrity. It is very shattering. In general, it is considered not as a distinct disorder. However, some consider it as a specific phobia. And I think it fulfills all the diagnostic criteria for a specific phobia as it was mentioned in the DSM-5. It can be a single entity, but mostly it was found concomitantly with another psychiatric diagnosis or another physical disorder. Death and anxiety is an area which I would like to draw our attention to it. It has the potential to profoundly interfere with the human psyche. It is different from necrophobia, which is fear from seeing dead bodies. And it's in its most important and powerful form it is existential death and anxiety. It is anticipatory because the basic belief and the basic knowledge that human life must end. So it is a form of existential anxiety. The term anger enemy or anger animi, I heard this term in 1979 from late Professor Siddiq Ahmed Ismail, alayhi rahmatillah. At that time, I just finished my hardship period, and I came and I joined his unit in Mustashfa Shab. A 52-year-old patient came with chest pain, and the patient is saying that I'm going to die. أنا حموت يا إخوانا صدقوني. أنا أرى الموت. أنا أشوف الموت أمامي صدقوني. Then myself and two other junior colleagues who have been attending this patient, and then Professor Siddiq came. He said, do you know what do we call this? We call it anger animi. Anger animi it was described by a professor of cardiology in 1925. While he's teaching the medical student, he developed acute myocardial infarction, and he started to describe to the students what he is going through. He described his death until he died in front of them. So anger animi, we see it also in patients with panic disorder. The patient, when they get palpitation, is derealization, depersonalization, and especially when they feel the lightheadedness, which is associated with panic disorder, they do experience that this feeling of impending death. It is a true description, and it's a very clear perception. I heard it from some patients. So this is about anger animi or anger animi, as Professor Siddiq used to pronounce it. Okay, death anxiety is a form of severe anxiety characterized by fear of one's own death or the process of dying and what will happen after death. Sorry, I did see a slide. Okay. There is a large body of research in this area with relatively consistent findings. This anxiety is the normal human experience, yet it can be extremely pathological. It can be very tormenting to the patient, especially when they start to ruminate about death, about what is going to happen. I remember I have a patient. She's so preoccupied about what will happen to her father. He died about 2 months ago, and she's living a vivid experience of the situation in the grave. Is he answering man huwa rabbak ma rabbak ma dinak man huwa nabiyyak? She asked me, did you think that you'll be able to answer these questions? I don't think so. And she's crying, in a rather very, very obsessional way. death and anxiety is really underreported by patients because patients, they fear the accusation that if they talk about it, people, they will say that غير مؤمنين or they are weak. And it is underdiagnosed also by us, psychiatrists and psychologists, because there is some sort of really, avoidance. Talking about the unknown, about al-ghaybiyat, about death. Some of us consider it as not within the domain of psychiatry, or that we are not capable or we are not skilled to talk about to this subject about our patient. And believe me, if this issue of this anxiety is facing the patient, or if it is lingering in the mind of the patient, whatever you do for him as far as the treatment of his panic or OCD, he's not going to recover unless this issue was really explored and treated, and this anxiety respond extremely well to a proper CBT. Epidemiologically, good studies which were conducted. There is a comparison by Dr. Abdul Khaliq, the very senior psychologist who work in this field. He compared this anxiety between a big cohort from the States and Egypt, and he found that female report more this anxiety than male, in particular in the Arab and Muslim community. It is much more common among young people. This anxiety is really prevailing around the age of 18, 19, 20. And sadly, it is also common among children. Children, particularly now, those who are living in the war zones, what they see, on TV. And there is spike also around the age of 50. They found that high education and good social economic status might be a protective element from this anxiety. The very religious and not at all religious enjoy probably a lower level of this anxiety. That is quite understandable. Those who are religious, of course, they consider that themselves, that there is a chance of salvation for them, and they do believe in eternal life and life after death, and that they will be under rahmatillah. And those who are not religious, on the other hand, probably they don't believe in any sort of eternal life or azab al-qabr or khilafu. Higher rates of this anxiety were reported among healthcare professionals, medical students, and medical staff who are working with terminally ill patient, cancer patient in particularly. And it was noted that at the COVID pandemic also, some staff, they develop death and anxiety, which might mount to be quite pathological and hampering to them. So it is common among cancer patients, particularly female with breast cancer. And we know that breast cancer is very common. 1 in 8 or 9 women, they will have cancer of the breast, and there is a genetic aspects of it. So if a member of the family develop breast cancer, others might get quite anxious about it, to the extent that some of them, they might have death and anxiety, and probably they don't like to talk about it. Cardiac patient, as we said, HIV, and patient with COVID-19, and those who are around them. In general, patients who are having pathological death and anxiety, they have got other psychological manifestations, unable to adapt, and a bit of depression and anxiety. They have got that type of symptoms as well. Theoretical knowledge and research and clinical observation report a higher level of this and anxiety among patients with illness, anxiety disorder, hypochondriasis, those who are doctor shopping, and attending different medical specialties. I have a patient who had 42 colonoscopy within 2 years. moving from the doctor to doctors, and definitely has got fear of death from cancer of the colon. Thus, an anxiety should be an integral construct in assessment and treatment of patients with somatic symptoms. It's very important. I think we have to come forward. We have to ask patients in a very tactical way. And patients, when you talk to them about this issue, they really like it. Believe me, and there is some sort of catharsis, for them when you talk them about fears. But of course, some of us or most of us, we might feel that we are not qualified, to talk about this subject. I will talk, about the solution and how do you tackle it. This anxiety is very important as trans-diagnostic construct in patients with panic disorder, agoraphobia, social phobia, compulsive checker, specific phobia, and separation anxiety. And this is why we said this anxiety is the real issue in children, PTSD and substance abuse and depressive illness. Female diagnosed with anorexia nervosa are also more prone to have death anxiety or thanatophobia. How to diagnose it? Definitely, probably the best way is a clinical assessment, a thorough and detailed clinical assessment. I think probably is the best tool. However, there is some scales and inventory, self-report scales, and there is a important scale which is commonly used, which is Templar. This anxiety scale that is constructed in 1970, and then it was modified in 2006. It was translated, to different languages, including Arabic, Persian, Farsi, Urdu, and it is commonly used, and I think it is validated, and it's quite a reliable scale. But again, clinical evaluation is the most important diagnostic tool if you want to diagnose this anxiety. Why people fear this? I think that is natural because nobody wants to die. Nobody like this. This is it's a prohibited thing. Nobody like it, but it is an ultimate. It is something which also people that cannot escape. Sigmund Freud, and probably Freud is the most fertile brain of our time. Sigmund Freud had been obsessed, about this, and we know why he has been really obsessed about it. Two things we know: his theories about brain structure, and his theories about sexual drive. And by the way, Freud, most of his theories, they really stemmed or deeply rooted from his own life, from the complexities which he went through in his life. For example, this might be slightly outside the topic, but I have to mention it. Sex drive. Freud, his mother, Alimia, she is the third wife for Jacob Freud. And Freud has got two half brothers, Emmanuel, which is quite a stable man, married with children, and the other half brother is Philip. Philip is unmarried, he's single, he has got some behavioral problems, and always he has some problems with Freud, with Sigmund Freud. Unfortunately, he had an intimate relation, with Amelia, and that resulted in being pregnant. And then the outcome of the pregnancy is Anna Freud. Anna Freud is the sister, not the daughter. Freud have got two Annas, his sister Anna, and this was fathered by his brother. Freud knows about that. And this is really have been very stigmatizing to him. And a lot of authors, they think that his sexual drive theory and Oedipus complex and all what he mentioned about sexuality is due to this very complicated and complex family situation in which Freud lived. Regarding his book, Pleasure Beyond the Pleasure Principle, he started writing this book in 1920, and in 1922 he completed the book. It is a marvelous book in which Freud said the ultimate goal of life is death. And Freud described this as a state of non-thinking, a state of non-existence. And he's the first one to coin the term thanatophobia. And one of the most interesting views of Freud that people, they don't fear death because nobody believes in his death, but he believes in others' death. And this is, I think, to some extent, it is true. I mean, if you go to a funeral, يعني دفن مثلا تلاحظ إنه بعض الناس are not caring at all, cracking jokes, smoking, simply, probably, and they don't, they believe in the death of others and not in their own death. He also attributed death and anxiety to unresolved childhood conflicts. Okay. The theory of drive, of course, evolved throughout the course of his life, and he differentiated between life instinct, eros, and death instinct. Freud he wrote a lot actually in death instinct, and particularly after he developed cancer of the jaw and the palate in 1923. He was diagnosed with cancer of the palate, and Freud lived with cancer of the palate, of the jaw and palate for 16 years. And he has been practicing psychoanalysis and wearing a very crude prosthesis, which he needs to change in between sessions, or he will take the permission of his patient to go and clean it, and then he will come back. He had 24 operations, regarding, his cancer. I will talk about that later on also. And Freud, he considered this instinct as indicative of or expression of aggression, of immorality, being assaultive, being destructive, and this aggression, when of course it is internalized, it will lead to self-destruction and development of self-harm. Okay, the outcome of treatment of death and anxiety is generally good and extremely rewarding. I have a cohort of 24 patients who were diagnosed with death and anxiety by myself and one of our senior psychologists who is also interested in the topic. Age range from 16 to 52, but 70% of our sample, they are below the age of 24. 9 patients had panic disorder, so there is a concomitant, another diagnosed with 3 patients with OCD and 4 patients with pure death and anxiety, 4 patients who had got social phobia, and 4 patients with illness and anxiety disorder, that is hypochondriasis. They were treated with CBT because if you look into the type of thoughts which people ruminate about, definitely there is a lot of distortion, and there is a lot of negative schemata in their thoughts, which are getting quite automatic and very painful and tormenting to them. So a proper CBT really it will help. And I do work with a very good two systemic counselor, and we have a manual for that. And really, if a patient had the desire to go and meet any one of them, usually I do refer them to them. هم ديل يعني مش وعاظ. No, it is not وعظ at all. This is CBT. And one of my patients is Christian, and the other one is a Hindu. I said to him, if you want to go meet a Hindu priest, that if you think that is going to be helpful to him, he said no, he doesn't need that. Of course, we also give medication, and lifestyle management is also one of the most important line of management for this patient. Results: 12 patients recover completely, and 8 patients showed good, but to some extent it is partial improvement. 4 patients, unfortunately, they showed very little improvement, and 2 of them, they have got illness and anxiety disorder, and 2, they have got severe intractable OCD. Okay, the third topic which I'm going to talk about is life expectancy and physical health and mental illness. There is a really plethora of findings in the literature that psychiatric patients live 10 to 20 years less than the general population. Patients with severe mental illness, they live less, about 20 years. That is really worrying, and really, we saw it, honestly. We saw it, patient who died suddenly, patient with metabolic disorder, patient who they died, during their sleep. So there is an issue here. What are we doing to improve this situation? I do believe any good psychiatric service should have a multidisciplinary team in which there must be physician who is interested in metabolic disorder, of course, dietitian, and fitness and physical training. And so what can we do about this? I'm sure something can be done. First of all, as I said, the MDT team should have a physician. However, psychiatrists should be good physicians. But again, we need really specialized service. At the same time, I think we have to improve, our knowledge and practical skills in managing patients with metabolic syndromes. Doing a CBC and a comprehensive metabolic profile should be quite regular, a routine thing which we have to do for our patients. ECG, any good psychiatrist should know how to read an ECG. Automated reports are not very good. Unfortunately, in a JCI accredited hospital in the region with 72 psychiatrists, junior and seniors, only 16% of them, they can read an ECG. Only 16%. And that is really wrong. That is really should be corrected. Yeah, and even when you talk about some of our training, they will tell you all sorts of things, about GT prolongation, the difference between a congenital prolongation and acquired one. They will tell you about Trousseau de Bonte arrhythmias, all sorts of things you can. But when it comes to reality, I think we need to do more. This is really a matter of concern, and I want everyone to get this message. Please, we should be really patient advocate in caring for their health service. Of course, also the habit of prescription of medication, the polypharmacies, in particularly when you come for, when you are dealing with patients who are resistant or difficult to treat patients, the question of switching, of combining, of augmenting, really we have to be quite watchful about this. I have seen a patient who has got schizophrenia with negative symptoms, and he has been on 500 milligrams of clozapine for 2 years with no avail whatsoever, no improvement. This is not right, you know. How can we, yes, clozapine, if it doesn't work after 9 months, it means that it's not going to work. Yes, it is marvelous drug. It is quite helpful to our to 40% of patients who doesn't respond to other medication, you know, but we cannot continue like that. You know, even if you have got the facility, if you have got the money. So please let us give really importance to this issue. Then I will move to suicide and suicidology. We know about the famous book of Francis Fukuyama. I'm sure Ustadna Zain يكون حافظه تماما. I mean, Francis Fukuyama, when he published his famous book in 1992, saying that history had come to an end. There is nothing new. There is little of importance who would happen in the future. And then he was followed by David Lindley, who made a declaration, and David Lindley is a great scientist, that physics had discovered all that need to be discovered. Of course, Francis Fukuyama changed his views in the future, but still he might be right in so many ways, because the new things which comes to human civilization, I think within the last 20 years, is global terrorism and the climate change. These are the two things, you know, and both of them, they are destructive to humanity. There is improvement, of course, in technology, in science, but he considered it as just some sort of fine-tuning. Then Lister, and of course, Lister is known, very well known in the study of suicidology. He suggested that suicidology had come to an end. No new theories, no groundbreaking research. Society is escalating. Young people are killing themselves. I don't know if you agree with him or not, but I think his theory is quite interesting. We know that about 1 million people, or slightly less, they do commit suicide every year. Every 40 seconds to 35 seconds, someone is killing himself. In China, India, Japan, and Sri Lanka account for almost half of all suicide. It's the second most common cause of death among young people. Studies from India show that 65% of those who kill themselves are below the age of 24. And that is extremely worrying. Every day in India, 350 people are killing themselves. 75% of them are less than the age of 30. There is new trends in society, which were influenced by psychosocial, cultural, and environmental risk factors. Please, let us remember that family history of society should be taken as a serious risk factor. You know, is it a learned behavior, or is it because of sharing the same environment, the same genetic? But this is quite important, and always we should keep it in mind. Typology of society, you know, since the famous work of Emil Durkheim and then Bandura after him, Emil Durkheim, he talked about social integration and social regulation. We classified, or his typology of egoistic society, anomic, fatalistic, and altruistic. I think these they need to be revisited. And there is many authors now working on the classification and typology of society. One of the, I mean, I have a good connection with senior Indian psychiatrists, Professor Ashu, Professor Chandram. I do talk to them. I do meet them in meeting. I do attend the Indian Psychiatric Association meeting. It seems that one of the most important causes of suicide among young people in India is social embarrassment and feeling of humiliation. You know, if a girlfriend said to her boyfriend, "I don't like your hairstyle," he might go and kill himself. Believe me. Okay, scholastic performance, failing exams, parent expectation. These are all causes of suicide now. So it is not that severe psychotic depression alone. No, feeling of social embarrassment that will lead to demoralization, and decision will be taken because always there is ambivalency towards suicide. Shall I kill himself or not? The issue of intention also, sometimes intention can be very confused, can be alien, can be multiple. Also, the impact of internet and cyberbullying, it is something which we have to keep in mind as a new trend. One of the interesting things that I read papers from South America, from Brazil, and they noted that youngsters who are carrying secular views, they are more vulnerable to suicide, you know, than others. As I said, in India, sometime, you know, a member of family simply he doesn't want to be, you know, a burden on the family. Of course, economic problem, limited resource, and now even the dowry society. You know, dowry society used to be extremely common in India. Girls who kill themselves because their father cannot afford, you know, to pay their dowry. There is some decrease in it, but I came to know from colleagues, in particular in Tamil Nadu, now there is increase of it. Following natural, this is probably considered as a form of altruistic suicide, if you want to. These people are sacrificing, really, you know. Following natural disaster in India, for example, if there is shortage of rain and there is drought, a farmer, when he look to his cows and they're getting very weak, skin and bone, the first thing which he will do is going and killing himself. Altruistic suicide, of course, can be for political reason, can be for ideological reason, religious reason. Let us remind ourselves of the Japanese kamikaze pilot in the Second World War. You know, at the end of the war, 3,500 Japanese pilots, you know, they dive, you know, with their planes and explosive, you know, in Pearl Harbor. And that is, these people, they have not been depressed at all. They are happy. Before going into these missions, they are loving, they are hugging each other, and they go into their mission. Tamil Tigers, at the time of the war between the Sinhalese, you know, and the people, you know, and the Tamil Tigers, really they sacrifice these young men with their cyanide capsules with them because they don't want to be captured. They don't want to go to the enemy. And I have a colleague of mine in 1982. I've been working at St. Clement's Hospital in Ipswich. He's my contemporary. Believe me, he sent his only 2 boys to fight, and both of them, they have been killed. That is sacrifice. That is altruism. Palestinian martyrs, you know, there is a very good study which came from Tel Aviv University. It was conducted by psychiatrists and psychologists and sociologists. They examined 78 Palestinians who survived their, you know, suicidal mission, or their mission had been aborted and they have been captured. They have been analyzed. They have been seen by psychiatrists, and in a very good scientific way, they found that 82% of them, they have got a very good educational, economic, and family background. They are not depressed. They are not desperate. And this is quite important. So I think when we study suicide, and particularly altruistic suicide, really we need to go deep in the brain of these people. Even ISIL fighters, yes, let us call them terrorists or terrorists, but why? It is not only brainwashing or no, I think it is more than that. Okay, also some of the trends which we noted in society now, there is less number of suicidal notes. There is changing pattern of suicidal ideation. It is not only that people, they feel hopeless and aimless and helpless, so let us finish it. No, no. People they have got some ambivalency. Yes, that is true. But usually they have got different ideas from this, from what the traditional suicidal, mental state, which we do see. There is decrease of suicidal pact. I think people probably are getting less liable, less faithful to each other, in particularly lovers. So there is decrease in suicidal pact. And let us be aware of that. Sometimes suicidal assessment, risk of suicidal assessment, either clinically or using psychometry, in itself can trigger off suicidal ideation, for some patients. So please, let us be careful about it. I know of some cases which really they started to ruminate about suicide following assessment, and I'm sure our trainees they are aware of that, and we must be very tactful in assessing these those who are at risk of suicide, jumping or saying that life is not worth living, and that is, I think that is rubbish. We need to be more tactful. The anti-suicidal action of clozapine and lithium, I think it does indicate that there is a complex neurobiological correlates of suicidal behavior. We know that lithium is truly useful in those who have got suicidal behavior, even if they are not depressed, even if they are not schizophrenic, just personality disorder, situational reaction. So there is a neurobiological correlates. Do we need to add lithium to drinking water? You might laugh at this, but in Lithuania, 6-7 years ago, Lithuania was leading the world in the incidence and prevalence of suicide. However, Lithuania is a very strict Catholic country, but in spite of that, the rate of suicide extremely high. So they suggested that they can add lithium to drinking water. And I think one company, which is they put lithium in their bottle, and they have been selling it. But do we need to go to that extent? But I think the neurobiological correlates of lithium and clozapine as anti-suicidal, it is of great interest. Studies from UK at the time of COVID pandemic, studies from UK initially showed that there is a short-term decrease in suicidal rate. This is simply because people, they have been pulling together, they are getting together. It is a period of honeymoon. But after that, the overall rates increased. And this is probably due to frustration. The pandemic had been quite long. People, they have got financial difficulties. There is domestic violence. There is child abuse, sexual abuse, substance abuse. So at the time of COVID, suicidal rate increased. In some countries, it's like over. Okay, euthanasia and assisted suicide. This is a very topical issue. I have been following, this issue of euthanasia since it was legalized in 2002 in Belgium and the Netherlands. Euthanasia. We cannot talk about euthanasia unless we talk about the death of Freud. Does Freud really left a legacy on how to die? Because his death has been very interesting. And I mentioned that in 1923, Sigmund Freud, at the age of 67, Freud died in 39, and at the age of 83, He was diagnosed with hyperplasia of the palate and jaw, and after 1 year, it proved to be cancerous. So, and Freud had been undergoing a lot of operation, 24 operations, and he has been very determined, very solid man, very strong. You know, he wear a very crude prosthesis to conduct, you know, his session. Definitely there is problem with his articulation, but he is insisting to continue on with you know, his psychoanalysis. And at that time, as I said, he expanded a lot on this instinct, and even his last great work, which is his book, you know, Moses and Monotheism, which was published, you know, after his death, of course, in which it is all centered, you know, around this and how the Jews, you know, they killed Moses and the rest of the story, which you know. Okay, so Freud in 1938, Austria was invaded by the Nazi, and Freud, he is in Vienna, and he has been extremely wanted by the Nazis. So Ernest Jones, and you know Ernest Jones is a great psychoanalyst, and he is a director of International Psychoanalytic Society, and he insisted on Freud to flee the country. Freud said he doesn't want to go. He is nearly dying, and he would like to die in a dignified way and in you know, in his country. But at the end of the day, he was convinced to flee, to go to England, and he went to London, Hampstead, accompanied by his daughter Anna, his friend and physician, Professor Max Shore, and his favorite dog, Joffy. Freud continued to practice in spite of being extremely ill. But he started to tell his daughter Anna and Max Shore that probably he should prepare himself and prepare them that he want to die, and he want to die under medical conditions. And so there is a lot of discussion between him and Max Shore, and at one stage he insisted on Professor Max Shore that to give him 2 injections of morphine. He doesn't want to die from 1 dose. He wants to die from 2 doses, as if he wants to negotiate something with death. Max Shore, he said, no, you are not terminal. Sigmund Freud said, no, we are terminal from day 1. And things continue in that way. And Freud has been writing his book, you know, Moses and Monotheism, Musa wa Tawheed. That is really unbelievable, you know. One day, you know, his favorite dog, Joffy, left him, kept away because the wound is getting so fungated and ulcerated, very foul smell. So Max Shore said to him, that is the moment. And he gave him the first dose of morphine in the morning, and the second dose at about 5 p.m. And Freud died by euthanasia on the 23rd of September, 1993. So if we want to talk about euthanasia, we have to remember how Sigmund Freud died. And there is a very good book written about the death of Freud. Okay, euthanasia is the act of deliberately ending a person's life to relieve suffering by medical means. Assisted suicide is the act of deliberately assisting or encouraging another person to kill himself or herself. The difference between the two, that is the final act in assisted suicide should be done, you know, by the patient himself. And we will know when we talk about Jack Kevorkian, who was a pioneer and a strong advocate and proponent of assisted suicide, when he assisted Mrs. Janet Atkins She's a 54 years old patient with Alzheimer's disease, and Kiefer Cohen, he claims that he consented, but there is a lot of doubt about that. What he did, he prepared what they call death machine, in which the patient, he fixed the IV line, and when the patient just asks her to move her arm, the fluid will go in. So the final act in assisted suicide should be done by the patient himself. Of course, this is just it is a sort of playing around with things. Euthanasia can be classified into voluntary euthanasia. A person make conscious decision to die and ask someone to help him. It can be non-voluntary euthanasia. A person is unable to give a consent. In case of coma, another person took the decision on their behalf, but there must be some sort of advance directive by the person himself. This is really now very controversial. And then, of course, there is passive euthanasia, which is causing someone this by withholding or withdrawing treatment from him. And this is again, يعني لما يقول لك يا أخي ارتاح خليه يرتاح, are you really prolonging his life, or you are prolonging the act of this by giving him antibiotics for repeated infection? This is again, it is very interesting. Okay, involuntary euthanasia is a medicalized killing of a person without the person's consent. And you know the story of Dr. Shipman, the famous Scottish general practitioner. Dr. Shipman, I mean, he was accused of at least killing 250 elderly patients. He has been quite a likable doctor among the patient in his practice, but it was noted that he's using obese morphine quite excessively. And at the end of the day, it was discovered that he really forget, living wills of some of his patients. And he was, at the end of the day, he was charged with serial killing. There is a 15 count of murder, against him. But Shipman never admitted his guilt. And that is one of the most astonishing things, He said, I think probably he started as a case, of really true euthanasia. But at the end of the day, even the doctors who used to sign the cremation certificates and the death certificate with him, they have been accused. But at the end of the trial, they gave them not guilty terms, They have not been really convicted for anything. Shipman, he at the age of 17, he had been beside his mother. His mother had cancer, and she had been in terrible pain. The physician used to give her diamorphine. And probably this is one of the things which, affected him in the future. But it is one of the most prolific serial killer in the medical field. And probably he started as someone who was advocating euthanasia, but he ended as a serial killer. In recent years, the involvement of psychiatrists and psychologists is getting less. And that is the most important thing. Patients who request euthanasia, in particular, in Belgium, because the Belgium, the Netherlands, Switzerland, these are the lands of euthanasia. It started there. They used to be subjected to a thorough psychiatric examination regarding their capacities. Are they suffering from depression? Are they suffering from any treatable thing? But unfortunately, now the role of psychiatrists is getting less and less and less. And even the guidelines for euthanasia, they are not implemented, particularly in Belgium. Believe me, now anyone with very minor, diseases or an illness, he can go and ask for euthanasia. And that is really worrying. It is truly worrying. Euthanasia is one of the most active areas of research in bioethics. And I think we as psychiatrists, we need to play our role. Others, they want to keep us away. But I think we have to be there. We have to prove ourselves. So many things were taken from us. Temporal lobe epilepsy were taken by the neurologist. Delirium was taken by the physician. So please, yani, let us be aware of what is happening. The first country to legitimize or legalize euthanasia, of course, is the Netherlands in 2001. Belgium. In Belgium now, almost it is free. It is getting hundreds of people probably, and they're losing their lives through euthanasia every month. In the United States, in a survey, nationwide survey in 2013, 47% of the population supported doctor-assisted suicide. I don't know the situation now. We know that there are 6 or 7 states which are allowing euthanasia or assisted suicide, and some patients they do travel, from state to state to go to end their life there. So unfortunately, it is really gaining grounds, and it is something which I believe, it is horrible, which is facing humanity. In the UK, euthanasia and assisted suicide are illegal. But in an anonymous survey, which was conducted in 2009 among the medical staff, they found that 0.2 deaths in some hospitals are due to involuntary euthanasia, which was conducted by the medical staff on their own admission. This is in 2009, and in 2009, probably the incidence is going higher and higher. ياسر افتكر الزمن, لكن just I talk about Jack Kevorkian is a pioneer of assisted suicide. He's a Armenian American, and he's a strong advocate of assisted suicide. Probably he had been involved in assisting more than 130 people to die. He has been convicted for murder in 1999, but he has been always insisting in that you cannot compel people to live if they are suffering. And he died in 2011. And Jack Kevorkian, he is a jazz musician and he's a composer. Everyone thought after he was admitted, with renal disease and hematoma, and he has got pneumonia, that probably he's going to ask for end of life medically. But he didn't. He asked the nurses to play for him, his best favorite music piece. There is a video. Okay, I think people can see, this interesting video. This is only for minutes. This is the admission of Jack Kevorkian himself. You can see how he operates this machine. And shall we leave then?
First tonight, the legal and moral questions raised by a widely publicized case of medically assisted suicide. On Monday, a retired doctor and euthanasia advocate used a machine he invented to help a 54-year-old woman take her life. The woman, Janet Adkins of Portland, Oregon, was diagnosed as having Alzheimer's disease and wanted to end her life. Her husband spoke of that decision.
Her decision that had been made some time ago, the boys were all familiar with it, and we all knew what she wanted to do.
Mrs. Adkins traveled to Michigan, where Dr. Jack Kevorkian, a retired pathologist, connected her to his invention, a device that first releases a drug causing unconsciousness and then a lethal dose of potassium chloride.
And this stops the heart as soon as it reaches it. So he has a heart attack in deep coma, which is like dying in your sleep.
Mrs. Adkins' suicide took place in Kevorkian's van in a local park. The doctor then called the police to report the death. They're now determining whether to press criminal charges against him. Dr. Kevorkian had this reaction to the possibility of being prosecuted.
If I'm a criminal, then you can look at me and say, you're a criminal, then throw me in jail. But keep me there, because if I get out, I'll do it again. I want this to be a medical service that's controlled. It isn't now. It's all hit or miss. Lay people are shooting each other and suffocating each other and poisoning each other and drowning each other. That's silly. How can doctors stand by and watch that?
We're joined now by Dr. Kevorkian, who is in Detroit. Doctor, you've been listening to this. I don't know whether you heard all of it, but basically all three doctors say that in this case, from what they understand of it, it was difficult to understand how you could have correctly diagnosed the condition and given Mrs. Adkins the medical treatment she deserved. Can you respond to that?
Well, I relied on the medical reports that were submitted to me that they sent from Oregon, in which the diagnosis was 90% sure Alzheimer's. Of course, that's a clinical diagnosis. And then I called her own physician, who was supervising her last experimental treatment course with THA, and he verified everything they said, and everything was in the records. And then when I met her personally, I could detect very clearly. I spent all day Saturday and most of Saturday evening and afternoon and evening with her and her husband and best friend. And from what I could see, she was having a terrible loss of memory, having trouble spelling, couldn't even print her own initials without great help, had trouble reading because of the memory loss, but she was rational, knew where she was, knew who I was, knew the time and place. And I concluded then that I had to go along with her wishes based on what I could see and determine.
Let's just give you an opportunity to explain your own rationale in your own words for assisting her in this suicide. What do you hope to accomplish with this clearly demonstration case?
Well, I want to show that I want to demonstrate my cardinal rule in ethics, which is personal autonomy. And the patient has a desire and a wish to end his life. It's up to a physician with his medical expertise, combined with logic and common sense, and a totally free mind to evaluate whether this person's desire and wish is medically justifiable. And if it is, then I think it's a physician's duty to offer that option to the patient. It's entirely autonomy, and that's what I wanted to demonstrate. And I wanted to demonstrate also that there's a great need for it in this country, and that the medical profession is responsible for a great lack of responsibility, and in that lack of responsibility has created much of the ethical dilemma in this field.
Al-homicide, I think now يعني, the most important thing is the age of criminal responsibility. You know the case of James Byler in this is 30 years back. You know, this is a toddler who was abducted by two 10-year-old boys, and he was brutally killed. You know, and now with all this development in technology, internet, the issue of competencies of children regarding committing a crime, I think it really need to be under revision. I think that's what is happening now. You cannot put a cut-off age, for the, regarding diminished responsibility. And a child of 7 or 8 now he can kill, and he can understand the intention that this is wrong and other. So this is all an area also. I think psychiatrists, not only forensic psychiatrists, any psychiatrist, should really work hard on that. The other thing regarding motives and intentions in murder, intention can be really alien, can be confused, can be multiple, can be changing. This is also an area which we need to be very careful. We need to be more strict, in giving psychiatric defenses, in case of murder, arson, and rape, and always you have to prove that the mind has no control over the action of the body, and that is not easy, actually. This is a lecture which I gave in 2012 at HMC, multiple victim killer. I think that's also interesting. There is definitely decline in serial killing, and there is increase in mass murder. Less or no feature of this and anxiety. This is very common among these people. And with sometimes, this, you cannot really reach any psychiatric diagnosis in them. Or as Lombroso said, they were just born to kill. Barakallahu feekum, jazakumullah khair. Shukran.
شكرا جزيلا دكتور محمد عبد العليم للمحاضرة الشيقة جدا. يعني it has multiple angles. يعني انت قدرت تغطي كمية من الangles. The topic it's very interesting. أنا هفتح الباب للأسئلة، لكن قبال كده بس أنا هسأل سؤالي أنا أول إذا عندي طريقة، which is the angle of suicide for trainees. يعني nowadays with the legal aspects of medicine, nobody wants to hear about suicide. The people have been trying to establish goals of zero suicide, which is questionable to be applicable or not. And when suicide happens in the medical field or basically in psychiatry, there is an overreaction, as if everything could have been preventable. Can you comment on this?
Yeah, of course. I mean, first, you have to understand that society is a part of, of psychiatry. It is a horrible thing, to happen. But also it depends, on the culture, on the situation in society happening. For example, in certain part of the world, probably, the physician in charge of the attending, he should prepare himself, to answer the coroner, the police, the attorneys, and all sorts of things, But I think the event itself had quite a negative impact on anyone who has been dealing with the patient, either in the outpatient setting or in inpatient or in the daycare. I think the most important thing for a trainee is really to show, empathy and sympathy at the same time, to be composed, don't feel guilty. You have to be ready, to answer, all questions by the mortality, morbidity committees or whatever it is, the police, the attorney. This will come later, and definitely they have to involve the seniors immediately. If it happened at the middle of the night, someone must inform, the consultant, in charge. I think even sudden death, sudden death in a psychiatric ward sometimes also is very horrific, and a lot of people, they get things get very chaotic. So I think medicine is based, on truth telling, say the truth and always act, upon that, and be composed, is, strong, and I'm sure they will get a lot of support, from their colleagues, from their senior. But I think, the culture, for example, in this part of the world where we are working, you have to be very compassionate, if there is a funeral, you have to go, you have to meet the family, that is quite important, and probably in other part of the world. So that's an important part, for the training. Probably other colleagues might comment on that. I can see Dr. Sobhi, the senior colleague, and Dr. Zain. If anyone want to comment, I think it's okay.
The floor is open for people who wants to comment or for questions. شفت دعاء, he wants to ask a question.
ايوه السلام عليكم. شكرا يا ياسر, شكرا يا بروفيسور عبد العليم. Very important topic, وبعدين I really appreciate the extremely high quality content, very comprehensive, touched upon many aspects of the death related to psychiatry, and it was really very nice to have that overview. الليكشر ذكرتني بكتاب زمان فاز بالبوليتزر برايز اسمه The Denial of Death كتبه سايكولوجيست امريكي اسمه إرنست بيكر. وواحده من الحاجات اللي كانت انترستنج في الكتاب ذاته انه قال denial of death ده is so prevalent and it impairs the human psychological development. he linked it للايديا بتاعت انه احنا as people or as species ما عندنا الكاباسيتي to appreciate that we're creatures. فالحاجه دي كانت very striking. وبعدين for my own career as a psychiatrist برضو لاحظت انه talking about death و talking about the other stigmatizing topics like sex مثلا is very hard. Most psychiatrists just go on their career as if it's not a big deal. Like, and it really is a source of tremendous pain. If it gets tackled, it can really help you grow as a psychiatrist, and it can help the patient overcome their difficulties. So it's a very, very good topic, very hard to hear even, but it's a very important topic. Thank you very much. Now, the question has to do with الحاجة اللي عندنا احنا أو كانت زمان أكثر أفتكر it's less prevalent now, which is the mode of suicide في السودان, especially among females, by self-immolation or burning or by ingesting hair dye. Yani these are just extremely horrific modes of killing oneself. Just what has been your own reading or your own experiences in this topic, and sticking to the theme بتاع linking this to the social frame, زي ما اتكلمت عن الرايتر زي ناس ديركهايم وكده. What has been your own views on that topic and this specific mode of suicide?
Of course, you know, the means or the mode which the individual choose to kill himself, probably it is indicative of his psychic pain, you know, and if it is very aggressive, it means that the level of pain is really high. Some people, they haven't got the courage, you know, to face a very horrible death. So even if they want to kill themselves, they might go for, you know, for overdoses, alcohol or something. I think society, you know, is quite fashionable like anything else, you know. In the past, they know that setting fires or going and drowning in the river, you know, is probably, you know, is the most effective means, and it is something which is available. الصبغة, الpoison. So I mean, it changed, you know, with the time and with the, you know, with the means. Buddhist monks, you know, the self-immolation, you know, at the time of Vietnam War, ما شاء الله طبعا أستاذنا الدكتور الزين يتذكر هذا, كان البوديست monk, and they sacrifice themselves. This is one of the top means of altruism. يعني they choose the most harsh way, the most painful way. Usual altruism, يعني there is a connection between altruism and the means. You try to kill yourself. Look, you know, to the Palestinian, look to the kamikaze, Tamil fighters. So I think there is some sort of proportion between altruism and at the same time you know, what the means which are really available, you know. So that's what I can say, Yasir.
شكرا جزيلا.
الله يسلمك.
شايف في سؤال وفي دكتور صبحي عايز يعلق.
جدا.
دكتور صبحي, unmute yourself.
افتح المايك.
Professor Abdelalim, it's very informative lecture. You didn't leave anything for anybody to comment. Just
thank you very much.
Just one of the things which I would be more interested in is the thought process of the parasuicidal people rather than actively suicidal person. Another thing which I have encountered few of the test anxiety people. And one of them, I think, was frightened of the عذاب القبر.
نعم.
أنا مسيحي, ف whatever I have done, I wouldn't have been able to convince him. So I referred him to a Muslim psychiatrist. Because there is religious also area to be discussed around that. Thank you.
Yeah. Actually, one of our CBT program, you know, if you think that you are competent enough, you know, to involve yourself in discussion, which probably it is of religious background, I think that would be more helpful to the patient, because you have the status of the healer, you know. And if you don't feel that you are capable, and the patient, you know, I mean, you did very well. You refer him. So as I said, they have two very good counselor, you know, extremely good counselor, and really هم يعني ناس يعني فراحيين، يقولوا شعر، يقولوا فالمرضى يحبوهم جدا جدا جدا، and they are very convincing. وبعدين انت لما تقول للمريض يعني simply في اشياء، هم they have got a lot of distortion in their thoughts, and that is one of the things, you know. يعني انت simply اذا توريه انه يعني رحمة الله يا اخي اعلى من كل شيء، اعلى من الموت واعلى من نفسك واعلى من نفسي، فانت انت ليه ما تعيش على هذا الامر؟ وبعدين الحقيقة ما مكتوب في عذاب القبر مرات ذاته it is very distorted even in our Islamic you know literature. يعني انت you don't know what is right and what is wrong. ف some sort of يعني results are really يعني very good, you know, in dealing with this type of situation. لكن طبعا قطعا الواحد اذا ما شعر انه هو he can deal with it يعني يحول يعني لنظر كلي. وانا صراحه my patients يعني سوري يعني اقولها بكل تواضع، معظمهم يقول لي لا نحن عايزين رايك انت في الموضوع. فيعني من هنا يعني الاشياء الواحد عارفها بتكون صراحه يعني لكن هي مش وعظ ديني. no it is not. ما بتكلم عن ايمان ولا بتكلم عن كده ولا بتكلم يعني let him يتعشم في رحمه الله. وان الذي يحدث هذا يعني ليس بهذا التصور وليس بهذا الذي يعني يحدث كده. وبعضهم طبعا الفير اوف ذا داينج بروسيس، يعني سكرات الموت ويعني سؤال الملكين مرات ده very specific. يعني واحد قال لي يعني خروج الروح يا دكتور محمد قالوا حاجه صح، وقلت له والله يا اخي الذي اعرفه انه كالشعره في العجينه يعني للمؤمن. فما تسمع الكلام اللي بيقول لك، اسمع دي انك انت ان شاء الله انا وانت وكلنا ارواحنا تخرج يعني كالشعره من العجينه. فهي صمتو، لكن عندنا structure program و I think it's helpful. بالنسبه للباراسوسايد فعلا يعني الباراسوسايد definitely if they have got suicide ideation, through suicide ideation they have got ambivalence as well. يعني sometimes they are very ambivalent about it, very ambivalent. Shall I do it? Shall not to do it? And a line of demarcation between those who are just يعني asking for help, it's a cry for help or attention seeking. Sometimes it is extremely difficult يعني to differentiate. أنا شخصيا يعني بنقول للتريني يعني take it serious. لكن when you are assessing any patient يعني عنده suicidal ideation or he tried يعني suicide, you must be really therapeutic and motivational. You should be motivational in your interviews يعني with these patients. لكن if you go with them asking these assessment questions or using one of these scales, I think يعني فهم they are usually ambivalent about it. شكرا دكتور.
في اسئله من الشات، وفي عندنا سلمى رافعه يدها ما قادره ترفعه في الزوم، وفي ياسين عايز يسال سؤال. لكن نبدا من سؤال الشات هنا. تسال سمر بتقول تتكلم عن الايرلي انترفنشن للchildren with death and anxiety. Can that help preventing the medications in the future?
طبعا this is definite. هو المشكلة it is a neglected topic honestly. And even I talk, I have got very good child psychiatrists working with us here, and they think it is an issue because now what children are seeing on TV screens, war zones, and if a death happen in the in the family, imagine a child of 6 or 7 when he see the body of his father is carried out, to the al-Maghabir. Imagine that, huh? And this is why we should talk to these children. We should support them. We will reassure them. But it is a very neglected topic, and even parents they are very evasive, and they will try to talk it. But if any child really has got that type of thing, and if you don't dig in really, you might not discover it. Any child with separation anxiety, with social phobia, any sort of phobia, I think we should keep in mind that he might have some bits and pieces also from death or separation from his parents through death, and what is going to happen to him after death, عذاب القبر والاشياء دي. بعدين الchildren طبعا they are also concrete to some extent. عذاب معناها عذاب، نار معناها نار، ملك الموت كيف بيجي دي. I agree with you, Samar, that we need to support them, we need to treat them actually, and I don't think there is any need for medication in this group of patients.
عندنا سلمى عثمان، ومخليني ياسين ينتظر شوية. سلمى عثمان عندها سؤال.
شكرا جزيلا، شكرا جزيلا يا ياسر، وشكرا بروف على المحاضرة الجميلة والتوبيك الرائع. شكرا لك. أنا عندي تعليقين actually. أول بس just follow up في النقطة الأخيرة تحت ال death anxiety. كان very interested case كان بس كان consultation بالتلفون من طفل في السودان. كان أبوه توفى، وكان he was unwell with cancer for I think a year ولا كده، المهم لحد ما توفى. فكان البرزنتيشن looked like panic disorder، لكن بس يعني شوية كده من اللياقة بتاع psychiatrist من الأسئلة وكده، فيعني it turned out إنه هو death anxiety. فبس أنا بس I wonder how many of our patients who come across with panic disorder لسه في underlying death anxiety behind it underdiagnosed. الكومنت الثاني الكومنت الثاني بس في كومنت في الشات على إنه السويسايد ريت ولا ده is not that common في بلادنا المسلمة. فأنا أعتقد إنه دي حاجة لو I think it's dangerous لو إحنا كسايكايتريست نفتكر كده ويكون عندنا اعتقاد ده. أعتقد إنه في حالات انتحار، لكن هل هي under reported؟ لأنه هنا إحنا عندنا الليكتشر تحت الريسيرش وكده في UK، لا بيقول لك إنه عدد تلتين حالات الانتحار they're not open to mental health services at the time of death. إحنا لو بنشوف 100 في الشهر، في 200 بينتحروا وإحنا ما عارفينهم. فبس بارك الله فيك، بارك الله فيكم.
شكرا دكتورة، والله تعليق طيب وجميل. هو طبعا بالنسبة للأندر ريبورتنج اوف السوسايد في بعض الدول هو متعلق بالديث سيرتيفيكت itself. أنا have been in a committee studying this issue، وفي بعض الدول الديث سيرتيفيكت مش أقول people they will try to write it as suicide, and sometimes they just leave it open verdicts or write how the rest. I think there is a problem, and also families, of course, they don't disclose sometimes suicide. The fear of shame and these things. Regarding the child, yes, I agree with you. In our interview and assessment of these children, we need to be extremely careful. And as I said, it is just like, you know, the suicidal ideation. We might trigger it off if we are not very careful. You know, and patients who are really suicidal, sometimes they are very clever, you know. They will try to hide, they will try to deceive, but inside themselves, you know, the type of the question sometimes might make the idea to materialize more, and they might go and do it.
سؤال من ياسين، خلينا ننتظر.
السلام عليكم.
ياسين القداد.
لا، ياسين أحمد علي.
حياك الله، حياك الله ياسين.
الله يبارك فيك. شكرا جزيلا يا أبو رفع على المحاضرة القيمة، وفعلا التوبيك المطروق في حياتنا اليومية، لكن من ناحية الشغل لكن الناس ما بيقروا عنه وبيكتبوا عنه كثير ويتعلموا عنه. فأنا سؤالي، أنا شغال حاليا في ليزون سايكايتري، وسؤالي عن الديث انزايتي. احنا بنشوف عيانين في الانبيشنت واردز بيكون عندهم فعلا characteristic death anxiety which has been lingering for months or years، لكن بنشوفهم at the peak of it، يعني في الكرايسيس الشديدة هو خلاص دخل المستشفى وحس انه الحكاية دي قريبة، والحاجة فعلا evident اللي بنشوفها انه الحكاية دي affecting الانجيجمنت بتاعهم مع الميديكال دكتورز، وانهم بيكونوا reluctant يعني to negotiate الاوبشنز حقتهم ويستخدموا الادويه والحاجات اللي بيدوها لهم. وانا يعني فعلا كلامك اللي قلته بتاع انه المقابله بس ذات الانترفيو فيها جزء علاجي، وهو ذاته بيرتاح اول ما تطلق معاه الموضوع ده ويحس انه في احتمال في هوب. وزي ما قلت العلاج السي بي تي برضه كويس، لكن احنا حاليا في الليزون سايكاتري ما عندنا اللكشري بتاع انه العيان بيقعد معانا مده طويله، وما عندنا ترين سايكوثيرابيست. فسؤالي، ما اعرف خبرتك شنو او تجربتك او نصيحتك في البريف انترفنشن، هل في حاجه كده ما بين الفائده البسيطه اللي بنلقاها من الانترفيو وبين اللونج يعني بينفيت مع السي بي تي، هل في حاجه في النص كده تعمل له في ال5 يوم ولا ال10 يوم اللي قاعد في المستشفى دي؟
نعم والله هو طبعا السايكاتري بروبلمز ار يعني multi factorial and treatment should be multi dimensional. عشان كده رويال كولج لما السيستم البايو سايكو سوشيال سبيريتشوال موديل يعني افتكر important فعلا someone who is يعني have a serious illness and is going to die definitely you need a lot of support. أنا أفتكر أنت just giving him hope, not hope to live يعني لكن give him إنه رحمة الله واسعة، يعني الأمور أفضل مما تتصور. تخلي واحد مثلا من المتدينين يجي. نحن الحمد لله where we are working we have got a very good strong spiritual يعني support. يعني we حتى من الأشياء very nice. قبل كم يوم قابلت واحد من الإخوة في السيمي كونسلنج في المستشفى، فهيز running يعني هو يعني بقدرني كثير. قال لي دكتور محمد صور يا اخي هتصل فيك الحين، انا ماشي لاحتضار، يعني في صومن يعني معتذر and he want to attend that يعني لانه these are difficult moments. فافتكر طبعا اذا كان الفاسيلتي بتاعت السبيريتشوال يعني موجوده، otherwise انا افتكر if he has got a relative انت الريلاتيف ده شفته يعني شوية يعني عنده جانب التدين، عنده جانب أن يبعث فيه طمأنينة، افتكر you can use him as a co-therapist. دي أنا افتكر دي برضو يعني ممكن تكون من الأشياء الواردة يعني. لكن حتى أنت لما تدخل عليك طبيب يعني تبسمك في وجهه، في أشياء يعني كثيرة يعني a lot of gestures يعني بتخرج المريض من الضنك والأشياء اللي هو فيها يعني.
نشكرك شكرا جزيلا جدا يا ابو رؤوف،
شكرا بارك الله فيك. شكرا الله يسلمك الله يسلمك.
نشوف اذا في اي زول من الحاضرين عايز يسال سؤال ولا يعمل ولا عنده اي اضافه.
انا دكتور ياسر طبعا الباوربوينت سلايد يعني ليكم كلكم بالله ميك افيلبل لاي واحد دائره، لكن الاخوان حقوا يرسلوا الايميلز عشان ترسل لهم على الايميلز لانه شويه الفايل يعني هيفي، لانه فيه فيديوز يعني جميله جدا، دي ما عرضناها، ممكن تكون مفيده لكم.
اكيد. بروفيسور رفع يده، كان عنده سؤال.
الو، مساء الخير.
مساء النور.
الو، سامعني؟
اي سامعينك دكتور.
ايوه، شكرا لك يا دكتور محمد، والله very interesting و very impressive و very stimulating talk يعني.
بارك الله.
انا سعيد انا سمعته او listening from the kick off يعني زي ما شايف.
ما شاء الله.
هذه مالتي
وانا سعيد اكون بعدك يا استاذنا، انا سعيد اكون الليكشر الثاني بعدك والله.
بالعكس، انا I was just listening. I was just learning. وقلت I give chances to our colleagues الاودينس انه يسال اسئلتهم قبل ما اعلق. والحقيقه التعليق هو مش تعليق، لكن زي ما انت قلت يعني you covered a multi-dimensional subject in the best way that one could do it يعني. لكن what's worrying me يعني عواجيز الطب النفسي، وانت you know I talk to you every now and then about this، وانا عارف انت اصغر مني بعشرات السنين، فمعلش.
لا لا لا
الشعب الابيض اسمه عندك.
الله يديك الصحه والعافيه يا اخي.
الله يطول. لكن تعرف وات اللي هو الديسبلين بتاعنا كسايكاتريست، زي ما انت قلت في الاخر يعني انه نحن سبنا الليجاسي بتاعت السايكاتري، لكن worried about the future of psychiatry rather than our future. وانت الدليريوم راح للميديسين، مش كده؟
راح للميديسين. نعم نعم.
والمالتي والديمنشيا راحت للنورولوجي
ايوه.
وما اعرف ويمكن تقريبا برضه
الديبريشن مشى للجنرال براكتيشنرز.
بالضبط. والديس انكزايتي برضه راح للشيوخ وكده، وكان الله
ايوه.
لكن الحقيقه اللي بس قلت اتذكر انه in the text of the lecture انه من الستينات، لو تتذكر انه انت ذكرت في الاول حكايه السايكاتري as an industry of death. ذكر
نعم.
الكتاب ده في الميوزيوم.
اي نعم
صحيح. في الستينات ونحن
نعم.
اول ما جينا الموزلي، اتذكر جينا الموزلي نحن في بدايه السبعينات، وجدنا this is يعني a big debate في الانتي سايكايتري اللي ذكرته في البدايه.
نعم. ار دي لينج والجامعه دي.
ايوه. سايكايتري ذا اندستري فور ذس. والميوزيوم المعمول في كاليفورنيا في لوس انجلوس باي الكوميشن اوف ذا
نعم
ساينتولوجي.
ساينتولوجي.
بدأ بالساينتولوجي باي تشيرش، وكان
نعم
دي يعني founded by church، وكان mostly يعني supported by البروفيسور المشهور جدا توماس ساس ومارتن هوفمان. فكانت a very big يعني exciting anti-psychiatry movement، وكانوا يفتكروا انه السايكاتري هي industry museum for this يعني. when the patient how tortured والpatient how their rights are being violated we suffered at that time and we continued on. but fortunately اتذكر لما نحن كنا في الموزلي في السبعينات، بداية السبعينات، وكان معي بروفيسور يحيى عون الله مد الله في عمره، كنا نعمل في السوشيال سايكاتري. كان عندنا تيتوريال في السوشيال سايكاتري مع بروفيسور جوليان ليف، لو تتذكر جوليان ليف.
ايوه طبعا.
a pillar of psychiatry.
He's quite well, still well now.
Yes. And he's a very excellent يعني very charming teacher. فكان بيكلمنا عن السويسايد في across the cultural aspect of suicide. وانا اتذكر جدا كان بيتكلم عليه، قال انكم انتم في المسلم كانتريز انه you have got this belief, الفيث belief، ولا تقتل النفس التي حرم الله الا بالحق يحيى يتذكر هذا، انه الريليس بليك بتاعكم لا تقتلوا النفس التي حرم الله بالحق، لكن فالسويسايد ريت بتاعتكم far more less than في our western culture اللي هي فيها انه السويسايد they interject السويسايد to themselves and they commit suicide. حتى ظاهرة المسؤول والشخص المعني بموضوع إذا كان فشل أو عنده خط إذا كان فشل he will kill himself rather than kill somebody else. وأنتم عندكم إنه القتل النفس بالحرام، لكن probably الهوموسايد عندكم أكثر مما عندنا يعني. If you see my point, you know.
yeah. نعم.
فكان مركز I believe that still نحن we maintain that إنه عندنا هنا إلى الآن إنه زي ما أنت قلت، وده عشان كده بقول إنه السايكاتريست يعني a good psychiatrist, a good clinician should be not only a good psychiatrist but an excellent psychologist and first class psychologist and an excellent neurologist so that you cover the area. ده يكون لك السي بي تي اللي انت ذكرتها which is very important part of your treatment في الانترفيو. That's why the interview في psychiatry probably 50% of diagnostic tool of psychiatry is interview.
It is.
Professor Mahi كان بيقول لنا if you finish the interview which includes seeing the patient for that length of time and developing good positive transference with the patient and taking good history from the collaterals, if you fail to reach a diagnosis, you have probably lost the case. Very important. Well, this is the area where you can psychiatrists, they have still a great part to do. If you spend time with the patient, talking to the patient, مثل ما البيشنت يجي يقول لك إن والله لا فرار لا راحة في الدنيا ولا فرار من الموت والموت أفضل وكذا. You talk to him is not that نحن although being religious لكن being also scientific. It is true. يعني that's why it became a discipline now. يمكن 50 or more than 50 years ago, CBT was not as يعني instrumental as it is now. With the improvement in the techniques of doing it. And also I believe that a good psychiatrist should also be a good CBT trainee. If you talk to the patient about what he has achieved, what he have got now, if you look at probably Freud, while he was treating the patient, he has got a cancer of the jaw. So
for 16 years.
Yes, that give a good impression. How you as a psychiatrist, if you tell the patient about what he has got rather than what he hasn't got, that is part of the CBT which can prove the patient. But I quite agree that there are some people who just the mere mention of this might give them a very hard time. Well, you know that now we are probably from this anxiety we are hiding behind panic attack. But really, sometimes patients with panic attack, when they get the climax of the panic attack, as you said, and they feel that I want to die, I cannot breathe, I cannot do it. And sometimes patient might open the door to have a good breath, and he jumps out of the window and dies. So
that's right.
I thought I should mention this point just as a contribution. I mean,
طبعا أحسنت يا أخي، أحسنت كالعادة والله. نعم أحسنت. Thank you very much.
Thank you very much.
الله يبارك.